Okay, so we're going to finish up the last little bit of diabetes, and then we'll move on to thyroid. I have, just for time constraints, either do you want to do a Kahoot today or case studies? Kahoot. Okay, we'll do the case studies on Sunday night as we'll go through it. I'll post it for you guys so you have it, but I can go through the case studies on Sunday night for the review. Cardio, at 10 o'clock we'll do cardio. We're going to do heart failure today. It's only a 70-slide lecture, and then we have a 30-slide for pulmonary hypertension. We also have a class on Monday at 2:30, which is going to be like a review session, sort of. I know Dr. Ovalle already gave you an hour review that she posted from last year. Same material, so you can go off of that as well. Okay, so gestational diabetes, obviously in pregnant women because it's gestational. I can't see now. Okay. Obviously, Native American women goes up because we know that the population in those populations already have a higher risk of diabetes as it is. Usually, the second half of the pregnancy, when they develop the diabetes, may recur with subsequent pregnancies. So if you had gestational diabetes for the first pregnancy, high likelihood that you'll have diabetes, gestational diabetes for the second pregnancy as well. And recover and will resolve with delivery. Once the baby's out, everything goes back to normal. However, you have a 50% chance to get type 2 diabetes later on in life. You kind of already like set the primer up in the body for the diabetes with the pregnancy. And then later on in life, it may come back again. And is routinely screened due to obviously the deleterious effects of the fetus when the gestational diabetes occurs. So all pregnant women will get screened for gestational diabetes. They'll just do that glucose tolerance test. You drink the solution, and you check your blood sugar every hour or so. And we see how those second and third hours are doing. So obviously, high blood glucose from the mother brings all that extra glucose to the baby, and the baby starts putting on extra weight, and that's how the babies get to a 13-pound baby. So, big baby. So high birth weight, fetal complications, brain issues due to this high reactivity to stress. So gestational diabetes has an elevated schizophrenia risk. Pancreatic problems, aberrant insulin production, so risk of getting diabetes later on as a child for that baby. Bone marrow and stem cell issues, high risk for leukemia and other cancers. Again, with the baby being born with gestational or having gestational diabetes in the mother. Heart issues, thicker blood vessels, may happen later in life, cardiac risk later on. And fat cells, changes to prompt the body to store fat, that leads to more weight gain. So the body's already ready to go to start storing all this extra glucose as fat. That's the role of insulin. We have all this extra glucose running around, all this extra insulin, and babies get very, very big. What this graph is just showing you is that as the age of the mother goes up, the risk of gestational diabetes also goes up as well. So that's all it's saying in this graph is just the older you are as a woman getting pregnant, the risk goes up for gestational diabetes. Is that a big problem? No, but things to watch out when you go through your delivery. So that was really all that happened. That was fast. Okay, we could have done that yesterday. Okay, thyroid disease. This is normally it was on around Halloween time, so it's all Halloween themed stuff. So you get pictures of Eli throughout various things. Okay, so disorders of the thyroid. Same thing that we've done with every other hormone. Do we have too much of it or too little of it? One of the other things we're going to start adding into this one is cancers with thyroid cancer as we go through this. So review a little bit. Here's our thyroid gland. Remember where it is located. We have our parathyroid glands as well. So remember to ask any patient that you see that had a thyroidectomy, one, what was the reason for it? Two, are you taking your thyroid medication every day now? And three, were the parathyroid glands left behind? Most of the time they are, but you just make sure you ask to make sure that everything's okay. 2 lateral lobes connecting central isthmus, very, very vascular. Obviously, a lot of the metabolism hormones come from the thyroid, so having it very rich blood supply allows for all these hormonal controls to happen. Histology, we have these parafollicular cells, and they secrete calcitonin, a very, very weak hormone with calcium metabolism. Inhibits bone resorption, so it slows osteoclast to lower the calcium levels. So we've only talked about calcium when it's been too low. And when calcium is low, what hormone comes out? PTH. PTH activates the whole vitamin D thing. So it's not the vitamin D, it's the PTH that causes the whole thing. But that's only in response to low calcium. Calcitonin, but it's very weak, is when we have high calcium. It slows the resorption of the bone, thereby reducing the amount of calcium being dumped into the bloodstream with the hopes to reduce calcium. We don't really use it for that. Calcitonin is usually a good marker for cancer. So when someone has cancer, or if you see calcitonin levels rise, it's usually underlying that they have some sort of cancer going on. And yeah, released in high levels of calcium, but it gets very weak. We have our follicular cells, and that is where the hormones are synthesized and stored as colloid. So the colloid is just these empty spaces that store your T3 and T4. And that's really all we're talking about. We have to deal with iodine when it comes to the thyroid gland. It's the only gland that really uses iodine. We have to convert it to iodide. Then this iodide is then taken up by the thyroid gland. Where do we get all of our iodine from? Salt. Mainly food, but it's the salt. So this iodine is absorbed, taken up by our thyroid gland. These follicular cells, they're the ones who start making the thyroid hormone, bring in this iodide where they start manufacturing it. It's called this iodide trapping. And then all this hormone is then dumped into the colloid where it's stored. Colloid is an empty space, and it stores the hormone ready to be released. This whole process is stimulated by your TSH, so your thyroid stimulating hormone. So when we have very, very low levels of thyroid hormone, we need to pick up this process. So what has to be increased? TSH, because we got to pick up our production. On the converse side, if we have way too much thyroid hormone, we got to slow this process down. So what happens to our TSH? It drops. That's where hyperthyroid and hypothyroidism come into play with TSH. It's the opposite with TSH. So here's our T3 and T4. There's a whole sequence of steps. You don't have to memorize this. What I want you to know is what's in red. Thyroid peroxidase, thyroglobulin, and here's another thyroglobulin here. These are enzymes. The thyroid peroxidase is an enzyme that helps with thyroid production. Thyroglobulin is the storage form of it. It's a way to store this thyroid hormone. If you have deficiencies in either of these things, what's going to happen to your thyroid hormone levels? They're going to decrease because you don't have the products to make it. So as we go through hypothyroidism, you're going to see people that have antibodies to either TPO, so they block the thyroid peroxidase enzyme from even working, so you can't make it, or they're going to block thyroglobulin, and now you can't store your thyroid hormone. If you can't make your thyroid hormone and you can't store it, what's going to happen to your levels of thyroid hormone in the body? They're going to drop. And that's what hypothyroid is. That's one of the forms of it. And that's why I want you to focus on the ones that I highlighted, because they have purposes later on. We produce 10 times more T4 than T3, but remember T3 is the more active one. T4 is converted to T3 in the periphery, so we constantly have that T3 kind of floating around in a controlled way. So here's our thyroxine binding globulin, which is what we're talking about here, thyroglobulin. We also have T4 binding prealbumin. Thyroid hormone, is it fat soluble or water soluble? Fat soluble, that's why it's got to get a carrier to get around. Can't dissolve in the plasma, so it needs a carrier. So it's got proteins. We got the globulin protein. We have this other one with albumin, and obviously albumin by itself. So it needs carriers to get around the blood, get throughout the body. And those are the ways we can do that. TSH is the most sensitive and reliable indicator of thyroid function and screening and following disease. So what that means is we use TSH to diagnose you with thyroid problems, but we also use the TSH as a therapeutic marker to see if we're in range. So we give you thyroxine or levothyroxine or Synthroid or whatever it is, and we want to make sure your thyroid levels are normal. How do we know that? If your TSH is within normal range. And we just increase your dose until you get into a normal range of your thyroid medication. So we use TSH to follow the disease as well. That's the marker we use. So anyway, I'll go back to this one. So when you have an elevated TSH, that means we have decreased function in the thyroid gland. When TSH is decreased, that means we have increased function. So it's the opposite with thyroid. Same thing with like ACTH with cortisol. When you have low cortisol levels, what happens to ACTH production? It goes way high. When you have too much cortisol, what happens to ACTH? It drops because you don't need it anymore. Same thing with the cortisol, ACTH, TSH, and your thyroid hormones. Here's your feedback. So make sure you remember all this stuff. Initiated with the hypothalamus with TRH. Then we go to TSH, which then T4 and T3. So there's our normal pathways. We've gone through this before. Just this is the ones you got to remember, these big ones. So what are the actions of thyroid hormones? A lot of metabolism stuff. Increased heat production, so a calorigenic effect, so you're burning calories like crazy. If your metabolism goes up, think of it like a campfire. The campfire is burning hotter. When your metabolism is higher, you're burning through wood like crazy. So when you raise your metabolism, you're going to burn a lot of calories just sitting there at rest. Stimulates oxygen consumption, tissue growth, maturation, lipid metabolism, helps with cardiac contractility, and with intestinal absorption of carbohydrates. So a lot of things with metabolism, energy, has to deal with your thyroid hormone. So if this is the normal, when you have hyperthyroidism, all these things are accentuated. They're sweating like crazy. They're eating massive amounts of food, but they're burning through calories and they're not gaining any weight. That's hyperthyroidism. They may get palpitations because of this excess thyroid hormone. So when you're studying the symptoms of thyroid, yes, we have to know the symptoms of hyper and hypo, but they're just opposites. Once you know one, the other one's just the opposite. If you have hypothyroidism, you're cold. You gain weight like crazy because your metabolism is slow. You have bradycardia, slow heart rates, all because of this altered thyroid hormone. So it does play a role, but when you're studying these things, only remember one of them and the other one's just the opposite. So again, here's our carrier protein. Remember that thyroid hormones act like steroid hormones. They have to get into the nucleus, okay? So that's where they have all their effects. That's why they have such profound effects on like metabolism of muscle growth, bone growth, because it gets into the DNA and starts turning things on to start growing things. So that's what how thyroid hormone gets around. Just another way of looking at things, once we get the thyroid hormone into the nucleus, we get all this DNA transcription, translation of the mRNA, and now we get new proteins, and this is where all the effects come in. It's just another way to review it if you like this type of chart better than the other one. Okay, so let's talk about thyroid pathology now. Okay, goiter, also known as simple goiter or diffuse non-toxic goiter, which means this is not really like, it's not cancer or anything, it's just non-toxic goiter, and just an abnormal enlargement of the thyroid gland, painless. When we start getting into these thyroid diseases, we're going to go through some symptoms. Some of them are painless, some of them are painful. Know when we start studying things, those are important things to keep in mind when you're doing these things. Can cause dysphagia. Makes sense. This is your thyroid gland. Look how big that is. It's going to compress all the tissues in the neck. Therefore, the esophagus will get compressed as well. Can cause some dysphagia there. Worldwide, goiter is due to lack of iodine. So that's why we put iodine in our salt. In the US, goiter is due to over or underproduction of our thyroid hormones. If we have reduced efficiency in thyroid hormone synthesis, so the way that we make it and package it is reduced, we're going to increase our TSH to try and stimulate it to do more, and the thyroid will grow to overcome the deficiency. So you're having lack of thyroid hormone production. Either it's those TPO, the thyroid peroxidase, or is it thyroglobulin problems that are causing these issues with having low thyroid. But the thyroid gland is going to hypertrophy to make more thyroid tissue, to make more thyroid hormone to compensate. So the goiter is there to compensate, get bigger due to all this lack of iodine, iodine in worldwide, but lack of thyroid hormone. Also, etiology, autoimmune diseases. So Graves' disease, Hashimoto's thyroiditis. Hashimoto's thyroiditis we'll go through. It starts off as hyperthyroidism, and then it burns out the thyroid, and eventually you all turn into hypothyroid patients. So Hashimoto's is first hyper, then it turns to hypo. Nodular thyroid disease is a form of cancer now. We'll get to the nodules a little bit later on. So with lack of iodine, we don't make enough T4, T3, therefore there's no negative feedback on the hypothalamus. So TRH goes up, TSH goes up, all in the hopes of trying to get our thyroid levels up. With sufficient dietary intake, again, we have enough iodine to make all of the thyroid hormone that we need, so our negative feedback is still there and we're okay. When you're insufficient with dietary iodine, you don't have enough thyroid hormone, so that negative feedback is gone. So TRH increases and TSH increases. Here's another one. Okay, so hyperthyroidism. So definitions, thyrotoxicosis is just a state of thyroid hormone excess. It can include hyperthyroidism, but basically there's just a large amount of thyroid hormone in circulation. That's called thyrotoxicosis. Hyperthyroidism is a state of thyroid hormone excess as well due to excessive thyroid gland function. So it's overacting. It's going crazy. It's pumping out tons of thyroid hormone. So large amounts of thyroid hormone get dumped into circulation. When we talk about hyperthyroidism, we have to classify it. Primary and secondary, so we have those again. Primary is a problem with the thyroid gland itself. Secondary is an outside cause of why they're having thyroid issues. You can have thyrotoxicosis without hyperthyroidism, and the reason is people are just taking thyroid hormone excess. For some reason, they're taking more of it. So that's called factitious or false. Also, you can have iatrogenic, which is due to a treatment problem. What drug did we talk about that can really mess up with your thyroid hormone? Amiodarone. Okay, so if you know part of the treatment can cause thyroid problems, you check your thyroid hormone before you start these amiodarones or other type of drugs to see what's going on afterwards. So primary hyperthyroidism, Graves' disease. The most common cause of primary hyperthyroidism is Graves' disease. We'll go through that in a second. And then you have toxic nodular goiter, toxic thyroid. These are your cancers, and iodine excess. So these are all cancers or whatever within the thyroid gland itself. Here's secondary hyperthyroidism. A TSH secreting pituitary adenoma. Okay, we talked about with the pituitary gland, you can get cancer in any of those type of cells. What type of cells would have a cancer if was producing a ton of TSH? In the pituitary gland, what type of tissue cells? What are they called? Thyrotrophs. Yep. So thyrotrophs. Remember all the different cells. You have somatotrophs, which make what? Growth hormone. Okay. Somatotrophs. I'm sorry. Soma is body. You have lactotrophs. Prolactin. Okay. Gonadotrophs. Nope. Oh, you're right. You're right. I'm the hypothalamus. Yep. FSH and LH. Yeah. Or you can have an ovarian tumor containing ectopic thyroid tissue. So an ovarian tumor that just for some reason has thyroid tissue there, and it's pumping out T4 and T3. So toxicosis without hyperthyroidism, again, you're taking excess thyroid hormone. You have damage or inflammation to the thyroid that just causes a lot of release of T4, T3, but it doesn't increase the production. So remember, we have all these colloids, right, that just store the thyroid hormone. When you have a problem, it can just dump all that thyroid hormone out that it had stored. That's what we're talking about here. So it just causes inflammation, damage to the thyroid gland, dumps whatever stored thyroid hormone we had into the bloodstream. We're not making more. It's just that whatever we had gets dumped out into the bloodstream, so all this thyroid hormone gets dumped all at once. Any destructive process of the thyroid, subacute thyroiditis. This is painful. So I mentioned those lesions. Here's one of them that's painful, and silent thyroiditis is painless. And again, examples of iatrogenic causes. Here's your amiodarone again. Interferon is another one. You'll start learning about all those when you get to like oncology drugs, which will come in a little bit this semester. So Graves' disease, the most common cause of hyperthyroidism. It is an autoimmune disorder. Young adult women, most of the time, 10-to-1 ratio, strong family history. So anyone else in your family have any thyroid problems? Here is another important part. Thyroid gland is symmetrically enlarged. So when you do your palpation for the thyroid, you're all experts at this, right? So you want to feel the lip, the top of that thyroid gland come up and pop up. You'll feel it abnormally on one side versus the other with certain types of cancer, thyroid cancers. It's a asymmetrical enlargement or a symmetrical enlargement. With Graves' disease, it's a symmetrical enlargement. The entire gland enlarges. So with Graves' disease, what's going on with Graves' disease? We have a TSH receptor autoantibody called TSHR. Be very careful the way that you write these things because there's another one. It's called an anti-TSH receptor. So get them straight. Now, with Graves' disease, TSHR, it's stimulatory. What this does, it sits in the receptor on the thyroid gland for TSH. And it turns on that thyroid gland to go overproduction. That's all it does. It sits in the receptor for TSH, this autoantibody, and turns on the thyroid gland to make more and more hormone. Okay? And turns them on. That's all Graves' disease does. It's an autoimmune disorder, produces these antibodies. It's a TSHR antibody. Thyroid becomes very hyperplastic, very vascular. So these same antibodies may also be involved in the eye changes seen in Graves' disease. What do you see? What are you looking for? Yep. Bulging of the eyes, right? So you start seeing some changes. This is one of the reasons why they have these changes, because they have the same receptors on the back of the eye as they do in the thyroid. So if they get bigger, it pushes the eye out, so the eye bulges. So here it is. Here is our TSH receptor. Normally, TSH would sit there occupy that receptor when it's needed and turn on production. But in this case, with Graves' disease, we have this autoantibody, the TSHR. And this antibody sits in the receptor and turns on the thyroid gland to produce tons and large amounts of thyroid hormone. So they become hyperthyroid. Everyone clear on Graves'? Autoimmune process turns it on. Okay, so obviously we have increase in T3, T4, which causes TSH to be shut down. So they have low TSH but high T3, T4. There is a table at the end of this lecture that gives everything splayed out for you very nice and neat. Okay, so basically it just turns it on. Signs and symptoms, anything to do with hypermetabolism, sympathetic overactivity, irritability, poor concentration, tremor, hyperreflexia. These are signs of hyperthyroidism. So hypo is just the opposite. Okay? Labile, not really any type of affect. Poor concentration as well, no tremor, hyporeflexic. Here's your exothalamus, ptosis or lid lag. Again, due to the excess accumulation of tissue behind. Heat intolerance, so they have a very, very high, they start sweating like crazy. Warm skin, weight loss again. Here's your cardiac problems, palpitations, tachycardia, arrhythmias. Any elderly patient with a new onset AFib, check the thyroid, because that may be the problem. People that have the AICD implants, there's a thing called thyroid storm, what we talked about before, where all those thyroid stores just get dumped into the bloodstream. Well, that can cause a lot of effects with your heart rate and these arrhythmias. It can put you into a bad heart rhythm or a very, very fast AFib. The device doesn't know, is this a bad heart rhythm or a good one, and it starts shocking the patient. And they get shocked repeatedly because it's not a heart rhythm problem, it's a thyroid problem, and the thyroid hormone is constantly being delivered, so the heart goes crazy. So they come in the hospital, the device is going off every 10 minutes. It's the thyroid storm, and we'll go through that later on. Diarrhea may happen, muscle weakness, atrophy, and obviously vital capacity, respiratory muscles, some breathing problems as well. So again, enlarged thyroid, here's your exothalamus, and then other problems that happen with hypothyroidism. So here's your summary for Graves' disease. So what are the effects of having too much thyroid hormone floating around? Cardiovascular effects, heart rate goes up, pulse pressure is increased, circulation time is shortened because we're going so fast. Remember, we have filling problems now. Do you see where you have to start pulling in all your knowledge from cardio back when you're dealing with thyroid because it affects the heart? What's going on here? So start bringing in all these little things you're learning. Tachycardia is usually supraventricular. What does that mean? From the atria. And they can result in CHF. They can go into an acute exacerbation of CHF. We'll learn about CHF in cardio in an hour and a half or so. Metabolic changes. Increased hepatic gluconeogenesis. What's going to happen to your blood sugar? It's going to go up. The increased hepatic gluconeogenesis. So the liver is going to start pumping out more glucoses. So your sugar levels go up. Weight loss from increased BMR, our basal metabolic rate, despite increased food intake. So they're eating 2,000 calories, but they're burning 3,000 a day, and so they're losing weight. That's exaggerating, but they're burning more calories than they're eating, so they lose weight. Increased need for vitamins can lead to vitamin deficiency syndromes in these patients. Osteoblast and osteoclast activity is increased. So increased low bone mineral density, increased bone fragility, and increased defecation from increased GI motility as well. So they have some diarrhea. If they're having constant diarrhea from all these problems, what else are they going to start having? Possibly dehydration, more other problems because they're losing all this fluid from the chronic diarrhea from the uncontrolled hyperthyroidism. So it affects GUG. I don't know why this editing came out weird. In women, oligomenorrhea with decreased fertility. In men, decreased fertility and impotence as well. Ocular issues, proptosis, and your EOMs may be fibrotic. So you may lose your EOM movement when that happens. Skin, warm, sweaty, velvety. This is called pretibial myxedema. This is on the anterior part of the lower extremity. As I called it, orange peel texture. But this is a derm sign of hyperthyroidism, or even just thyroid disease in general. So pretibial skin may thicken, pretibial myxedema, or thyrotoxic dermopathy. Again, it's a dermatologic sign, but it's from an underlying hormonal imbalance. Non-pitting edema of the lower extremity. That's just thickened skin. It's not swollen from fluid. So if you squeeze that, it's not going to be like dough. It's just going to feel like skin. It's going to be hard and thick. Nodular plaque-like forms, that's what you're seeing there. Hyperpigmentation of lower extremity and nail beds. Again, this orange peel texture. What happens is deposition of hyaluronic acid and proteoglycans in the dermis. So we're thickening the dermis layer, and that's why it's such a thick skin. There's no fluid there. If you squeezed it, again, nothing's going to happen. Here's your, again, orange peel texture. You can see the orange looks a little weird on that one. And then here's your clubbing of the digits. This is what clubbing looks like of the fingers. So here's the major complication of hyperthyroidism. It's called thyroid storm, a massive dump of thyroid hormone in the body all at once. Can result if Graves is not treated. So that Graves, remember, it just turns on that thyroid gland and keep pumping out hormones. It is relatively rare, but it is a medical emergency, usually precipitated by some sort of other illness or surgical emergency. So fever's a big one, nausea, vomiting, restlessness, psychosis, so they have altered mental status due to this thyroid storm. Followed by CHF. And again, if you don't treat thyroid storm, it can become fatal. So you can die from this. Okay, there's Nacho Libre. Okay, so here's our hypothyroidism now, also known as myxedema, characterized by, again, abnormally low serum T4, T3 levels. Serum TSH is elevated in this case, trying to get that thyroid stimulated to do something. So let's look at this box on the side here. We have primary hypothyroidism. The primary problem is in the gland itself. In this case, TSH is high. Makes sense because the gland is not doing anything, but the pituitary gland still works. Hypothalamus still works. So TSH will still be active, but the thyroid is not pumping out anything, so there's no negative feedback, so TSH goes up. Secondary hypothyroidism. Now we have a problem with the pituitary gland. Do you see now why that makes sense? Pituitary is not making any TSH. So there's no TSH out to even stimulate the thyroid. So in this case, the thyroid gland probably works fine. Just that they're not being stimulated to do anything. So this is a secondary hypothyroidism, and this is pituitary issues. This last one has to do with what's called poor peripheral conversion. So remember, we convert T4 to T3, which is more metabolically active. What do we produce more of? T4. But we know we're going to convert the T4 to T3 later on. If we have a problem with that conversion of T4 to T3 in the periphery, TSH is normal because the thyroid gland is still functioning normally. Here's your T4 level. T4 is going to be normal. because you are producing the right quantities of T4. The problem comes when it gets to T3. Because there's no more conversion of it in the periphery, T3 levels still stay low. And if you see that combination, that means you're not converting T4 to T3 after it's already made. So these are some other differentiations with blood. So obviously you're going to have a lot of blood on this exam and levels. So primary hypothyroidism, damage to the thyroid gland itself. Congenital cretinism. This is a problem with developing babies. They have a poor functioning thyroid gland. They have no thyroid hormone, so their development is delayed. I think I have a picture. Yeah, it's coming up next. Here's our Hashimoto's, iodine. We're going to go through all these individually. Secondary hypo, problem with the pituitary gland, and we'll go through all these. So there's cretinism, maybe evident at birth or within a few weeks. Thyroid aplasia or hypoplasia. The thyroid gland didn't develop right or didn't develop at all. So we have issues with thyroid hormone now. Clinical manifestations include persistent jaundice, hoarse cry, constipation, somnolence, feeding problems, delay in developmental milestones. When you guys start peds, obviously they can't talk to you, they can't explain what they're doing or what they're feeling or anything, so a lot of what we have to deal with is just milestones. Can they do certain things by this age? Can they put a word, 2 words together by 6 months, whatever it is? Can they do certain things at certain times? With cretinism, because their development is delayed and brain doesn't function well because of the lack of thyroid hormone, they get developmental problems and they won't progress normally. So what you see here on the left is a baby that was born with cretinism before treatment, but you give them treatment and then everything goes back to normal and they'll develop normally. So it's a treatable disease. But again, if unrecognized and untreated, will lead to mental retardation because they're not going to develop. So catching this early, you give them thyroid hormone and they'll develop normally and they'll be fine. So catching it early, because if you mess up the development, they're going to be delayed in a lot of things later on. So it's important that they get back on track early. It's kind of like when we did like seizures. If kids have like those daydreaming seizures or the absent seizures, well, they're not paying attention in class. They're going to be developmentally delayed because of the lack of attention that they're going through. That's why those developmental things you'll learn about in peds are so important. So hypothyroidism, symptoms develop insidiously. They kind of just come on. Fatigue, cold intolerance. They get cold all the time. Boggy faces, puffy eyelids, edema of the hands, feet. Also due to these accumulated proteoglycans that mix the edema. So that same thing with they had in the hyperthyroidism. Hoarseness. They get thickening of the larynx. So the voice deepens and changes. Problems concentrating. Decreased sweating, cool, dry skin. Hyperthyroidism had moist, wet, warm skin. Slowing of the movements, menorrhagia, weight gain, constipation. Hyperthyroidism had diarrhea, going too fast. So again, opposites. You don't have to study both. Study one, and you know the other one's the opposite. Complications, again, untreated. Remember in this class, when we talk about all these complications, it's just if you don't treat them. If you treat them and they follow the regimen, they'll be fine. But what are they doing? So untreated hypothyroidism can result in what's called a myxedema coma. Very high mortality rate. Obviously, more occurs in the elderly. Usually going to be precipitated by an infection, stroke, or some sedative medications. Signs and symptoms, all of those, plus decreased level of consciousness and possibly seizures. So again, just a summary slide of all that stuff put together. Here is our Hashimoto's thyroiditis, also known as chronic lymphocytic thyroiditis, the most common form of hypothyroidism. Okay? 3 to 4% of the population, 3 times more common in women. So remember, these things are there for a reason. I highlight that for a reason, so know that women get hypothyroidism more frequently than men. Frequently diagnosed between the 3rd and the 5th decade. So what ages? 20s to 40s. So here we are. The presence in Hashimoto's of antithyroid peroxidase, anti-TPO for short, and antithyroglobulin antibodies, TGAB. These are 2 antibodies that will mess up production of thyroid hormone. Remember what I said in the very beginning of this lecture, the way we make thyroid hormone. We didn't know all the steps, but I said there were 2 major things in red. Here they are now. When these are affected, the whole production, the assembly line gets messed up. You can't produce thyroid hormone without these 2 things. With Hashimoto's, they may have one, they may have both, one or the other. But very high level of these thyroid antibodies will distinguish Hashimoto's from the other forms. So other forms of hypothyroidism may not have these antibodies, but if they do, that means you have Hashimoto's. It's a chronic autoimmune disorder. Here's our T cell mediated destruction, these CD8 cells. We have anti-TSH receptor antibodies. This is one of the big ones. So this is where I said, do not mess up the nomenclature. This is anti-TSH receptor antibody. Anti-TSH. The one in Graves' disease is called what? TSHR. This is anti-TSH. This is going to turn off the thyroid gland. Same principle. Sits in the TSH receptor, but it just turns it off. So this is one of the most common ones you'll see, the anti-TSH receptor antibody. Here's your anti-TPO antibodies. Peroxidase is used to synthesize T3, T4. When you have anti-TG or TGAB, this affects the storage of these hormones. So you can't store it and you can't make it. So thyroid levels drop. So these are the 3 types of antibodies that you will see with Hashimoto's thyroiditis. Again, you may see one, you may see multiple, but they're going to have one of them that tells you it's Hashimoto's. Initial presentation for Hashimoto's, painless, diffusely enlarged, so symmetric. Goiter lymphocytic infiltrate that builds up due to the autoimmune inflammatory cascade. So they have a swollen thyroid due to all the inflammation going on, due to the swelling from this autoimmune destruction. Eventually, the thyroid gland will atrophy after the cells die in some patients, and also associated with other autoimmune diseases. So in endo, in the winter, again, talking about those multiple endocrine neoplasias, will show up in some of those as well. So physical exam, painless, symmetrically enlarged thyroid gland, firm, rubbery, maybe in an irregular surface at the edges there and the borders, can impair swallowing. Again, the thyroid gland is getting bigger. All that soft tissue, what are the structures in the throat, in the neck? Know your anatomy, you see what's being compared. May only be one firm lobe or a single firm thyroid nodule, may be palpable. And remember, as the disease progresses, parts of the glands are destroyed. So it may feel weird because you're destroying part of that tissue. So it's going to go away, necrose and die off and atrophy. So you'll feel some irregularities on the borders there. Labs. 90% will have the anti-TPO. This is the big one. 50% will have the antithyroglobulin antibodies. They may have some cell membrane antibodies as well. T4 and TSH levels may be normal. They may have some peripheral conversion issues with Hashimoto's as well. So you may see normal TSH, normal T4, but T3 drops because it's not around. Okay. So Hashimoto's, again, signs and symptoms: hypothyroidism, slowed mentation, forgetfulness, problems hearing, ataxia. Here's your hyporeflexia, sluggish DTRs. Paresthesias, may get some carpal tunnel as well. Musculoskeletal issues, muscle weakness, cramp, stiffness, cardiac output, bradycardia is one of the big ones. They may have a higher incidence of sleep apnea, maybe due to the increased thyroid gland compressing the trachea while you're breathing. When you lay down, the weight goes on it, maybe due to that. Liver, they're going to have high cholesterol, high triglycerides due to this low thyroid function. Hematology, they may have a normocytic, normochromic anemia. GI, constipation, whereas hyperthyroidism, they had diarrhea. Skin, cool and dry, they may have a mixed edema there. Face may appear puffy with some coarse features. Hair is another big one. Brittle hair. Loss of body hair, like the eyebrows. They start losing eyebrows, the hair. Hair gets very thin and brittle on the hair, on the head. So hair changes. They may notice that first, and they come and get seen. Why is my hair falling out or whatever? It's going thinning. So here's some examples. Again, puffy faces. Here's a thinning of the hair, loss of the eyebrows, all signs of hypothyroidism. Any questions so far about hyper or hypo? Yes?
So there's going to be an enlargement in both hyper and hypo.
But the labs will tell you what's going on. But with Hashimoto's, it'll be enlarged at first, and then as the tissue dies off, it gets smaller and smaller and smaller. So it starts off big and then gets smaller. Let's take a break. Come back at 9, and we'll finish this up. Okay, we'll get started. So this last little bit is just on different types of cancers within the thyroid. They can be benign, they can be malignant, but we'll go through them as we go through this little section here. So the picture in the background is a thyroid gland. Obviously, it's cancerous. You can see the nodules, the bumpy all over it, the friability down there from the cancer. So nodular disease, we haven't said anything about being cancerous yet. It's just disordered growth of the thyroid cells. Gradual development of fibrosis. So is fibrosis good? Nope, we don't like it. Occurs in 25% of adults. Nodules may be solitary, meaning just one nodule. There it is. It can be multiple nodules. Do they have multiple on the thyroid gland? The last little bit is important as well. Is the nodule functioning or not? If it's functioning, that means that nodule is going to be producing thyroid hormone. If it's non-functional, that means you just have a mass there. It's not producing any thyroid hormone, not doing anything bad, but it's just a growth that's there. So we want to know the function of these masses as well. Do they do anything? So non-toxic, so we know it's non-cancerous, multinodular goiter. So they have multiple nodules all over the thyroid. Asymptomatic. So again, painless. 12% of adults, more females than males. Over age, risk goes up. Variation in the size of the nodules exists. We can have hypercellular areas. These are cystic areas, and they're filled with colloid. Remember, the thyroid gland has these colloids that have all the storage. Fibrosis can be there. They may have hemorrhagic or lymphocytic infiltration may also occur as well. So you get some blood going in there. Most patients are asymptomatic and euthyroid. So the thyroid is still functioning normally. Thyroid hormone levels are fine. They just have nodules there. Usually detected on physical exam, or the patient will say, I am having problems swallowing now, not even knowing that they have nodules on their goiter. Now, complications. If they suddenly get pain, that suggests that nodule burst, and that was a hemorrhage in that nodule, or it means it became malignant. So, toxic multinodular goiter normally is asymptomatic and painless. If it becomes painful, that means that one of those nodules either hemorrhaged or became malignant. Malignancy may also cause hoarseness because of that laryngeal nerve involvement. What other thing do we learn about that also can impact that laryngeal nerve? Very good. Excellent. So now, we are dealing with toxic nodular goiter. Now they are cancerous. These are symptomatic. So they are painful. Enlarged thyroid gland with nodules. One or more of these nodules produce too much thyroid hormone. That's called, again, our thyrotoxicosis. Too much thyroid hormone being put out there. Most commonly in the elderly. Presentation, here's your AFib again, palpitations, tachy. That's why I said before, any new onset AFib in an elderly patient, think thyroid problems. Nervousness, tremor, weight loss. Weight loss, again, these things. Why? Because they have elevated T3, T4. They're hyperthyroid, so they have hyperthyroid-like symptoms. So etiology, after receiving IV iodine or by mouth, can happen. So for contrast, CT scan or heart catheterization. So be careful with those things. Any medicine that contain iodine, such as amiodarone, may also make things worse. So you have to be careful before you give contrast to patients. Make sure the thyroid is okay. They don't have any issues with that. Obviously, you have to make sure what other system is okay before you give contrast. Kidneys. Very good. So a toxic adenoma, also known as a hyperfunctioning solitary nodule. That is one big follicular adenoma, pretty much encompassing most of that thyroid gland. Solitary, well-circumscribed nodule. One nodule, very, very tight, circumscribed around it, borders. Large enough to palpate. No signs and symptoms of Graves' disease, though. So they have this nodular there, this goiter, the solitary nodule. Produces thyrotoxicosis by itself, often mild symptoms. So we have to do some imaging. So what we do is it's called a thyroid uptake scan. We label iodine with nuclear isotopes, and then we inject the iodine with these little tags on it into your bloodstream. And wherever this iodine goes, we know that it's going to go to the thyroid. That's the only gland that really uses iodine. And we look at the scan to see where this iodine is going. Do you see a lot of that very, very dark black spot? That means that that area is taking up a lot of iodine in that one area. So it glows. It's a hot nodule. This is a functioning nodule, meaning it's going to take all this iodine in and it's going to spit out a ton of thyroid hormone because of this one nodule that's there, this one cancer cell that's there. So this is a functioning nodule or a hot nodule because it is undergoing the uptake. You remember like the cardiac nuclear stress test, right? Take a little bit of your blood out, we tag it with a nuclear isotope, put it back in, see where it goes. See where the heart being perfused. Same principle here. Yes, you have a question? So this is not contrast at all or anything. This is just regular iodine. We just tag it. So it's like normal stuff you normally have. It's not a contrast or anything. So it's a little different. Yes?
I thought you don't want to give thyroid or iodine to people with thyroid issues. I'm confused. Like, why are we giving them thyroid?
We're just doing it for a test. We're not doing a chronic thing, just to screen to see what's going on. Again, so this hot nodule, where it's being taken. Yes.
So is the adenoma the hot nodule?
Yes, that is the nodule.
And that's cancerous?
Mm-hmm. Well, you have to biopsy it, but normally it will.
Most
Yeah.
likely. Okay.
Yes. Yes.
Does the hot nodule have increased uptake or decreased? It's
Increased uptake of the iodine, yeah. That's why it glows. So think about wherever the iodine goes, it's going to glow on the nuclear image. So it's a hot nodule because it's glowing on the image. If you ever watched, so this guy, so he didn't know he had a toxic nodular goiter. People who saw the show noticed that and called in and wrote in letters saying, you check your thyroid, check your thyroid. He finally does, he got thyroid cancer. So this is an example, like when you start seeing people that enlarge lower here, like, don't take it seriously, and he got taken care of, he's fine, but that's that story. Now, this is a good slide to know because this tells you risk factors for malignancy in a thyroid nodule. So, genetic or environmental factors, radiation exposure. When you guys go to the dentist, what do they make you wear? Lead. If you anyone here work in like a radiology suite? But what else do they do? What else do they? What's attached to that? No, you have the collar. It's a lead vest, but then you also have a collar. What do you think collars for? Thyroid. So it has a collar that you would wear if you're in those surgeries when you go on rotations. If you're in cardio, they do a lot of the C-arm stuff. You wear the thyroid protection to protect against radiation. Obviously, Chernobyl's here, other nuclear test sites, anything to do with radiation can cause issues with your thyroid. Family history of papillary thyroid cancer or medullary thyroid cancer. Here's where the male sex comes into play. If you're a male that has a thyroid nodule, most likely it's going to be cancerous. In a female, it could be cold, or it's non-functioning nodule. Characteristics of the tumor. If the growth is fast, more likely to be cancerous. So how fast did this thing get enlarged? Vocal cord involvement. Obviously, the size of this thyroid got bigger to the point where now we're affecting that laryngeal nerve. Is it a fixed, hard nodule? The thing is not moving. It's fixed in one area. It doesn't really flex. They may have cervical lymphadenopathy along that chain. So they may have some popped lymph nodes. Dysphagia and stridor, because obviously you have more tissue swelling in a closed environment in your neck. All the compression of soft tissues causes all those problems. So if they have these factors, there's a higher likelihood that the nodule is malignant with these risk factors. This is the last one. Okay, so here is what I was telling you about. This is a great one as far as condition. This is normal. We have our normal feedbacks. With hyperthyroidism, we have low TSH and high T4. Primary hypothyroidism, high TSH, low T4. Secondary hypothyroidism, this is what, pituitary? This is a thyroid? Yes?
This is back like 2 slides, but isn't it a cold nodule more likely to be cancerous than a hot nodule?
Yeah, that's what Professor Brown said. Hold on.
Okay, I will look into that. Send me an email, and I'll verify that one. Okay, so here's my costume. If you ever watched Superbad? Yeah. Okay, and here's one more. Okay, let's go right into the Kahoot. I got it up already. Is it hot or cold? Look it up. But like, I would look out somewhere else. I'll verify. I'll make sure. Sorry. Neuro. Possibly endo, probably, but we may have someone else teach it, but neuro and endo for sure. Yeah, after today, guys, there's no more lectures with me. No more lectures with me after today until next semester. Yeah, you guys are done. Monday's last day. I'll see you guys in January. No, I'll be here.
I was like, you're not gonna come in.
No, I'll be here. No, I'll be here. Okay, we all in? Okay.
That was crazy.
Okay, what's the Z line? Okay, so what's this one? The esophagus to the stomach. Why is there a sharp demarcation there? What's the difference? Cell types. Remember, the esophagus does not like acid. Doesn't do well. Okay, someone who suffered a stroke are at risk of what due to disruptions in oropharyngeal motility? Now, if you guys are studying with questions like this, what would have to be in the question to make red or yellow correct? What complaint, what symptom would I have to mention if I said the answers were poor nutrient absorption and poor nutrient intake? What symptom, what disease did we learn about that has very, very, very slow gastric emptying? Gastroparesis. And what are the problems with that? Poor nutrient absorption because they're not being pumped out in an appropriate way. They get stuck in the stomach. We get poor nutrient absorption. So as when you're studying, that would have to be not the oropharyngeal motility, it would be gastric motility because that got reduced. Then those two answers would be right. Esophageal strictures. What disease causes esophageal or can result in esophageal strictures? All the GERD, the severe GERD, and if I get ulcerations and the skin starts touching, the tissue starts touching, it can fuse together, causing strictures. So in this one, obviously, oropharyngeal motility, swallowing is the problem. What is the main histological finding in Barrett's esophagus? They also have motility problems. Yep, going too fast. Okay, goblet cells. Goblet cells don't belong in the esophagus because what do goblet cells produce? Mucus. They're not supposed to be there. So a portion of the stomach protrudes to the diaphragm, causing upward displacement of the lower esophageal sphincter. What's that called? There's your diaphragmatic excursion. The only time you'll ever see that in a question, probably. I'm just kidding, but it's around. Hiatal hernia, very good. Remember that the opening part of the stomach pops up. What is the neurological cause of dumping syndrome? What are the only two demyelinating diseases we learned about? MS? GBS. MS and GBS are the only two demyelinating diseases we've learned so far. Non-selective vagotomy. You cut the vagus nerve, causes dumping syndrome. Gastroparesis is caused by autonomic dysfunction. That's why gastroparesis, think diabetics get it. Diabetics get autonomic dysfunction. So if the question was, what's the neurological cause of gastroparesis? Then you can say autonomic dysfunction. But we're talking about dumping syndrome. It's one of the answers was non-selective vagotomy. There were a couple other choices in your PowerPoint. Okay, what's the major enzyme that's deficient in congenital adrenal hyperplasia? Very good, the 21. Patient with congenital adrenal hyperplasias, what levels would you expect of cortisol, aldosterone, and androgens? Okay, low aldosterone, low cortisol, and high androgens. Remember, what enzyme is deficient? 21. You need 21 to make cortisol and aldosterone. If you don't have it, all that cholesterol gets dumped into androgens and you get high androgens. Which of the following is a lab finding seen with Addison's disease? So you have to know what Addison's disease is first. Then you know what levels are going to be high or low, and you go from there. What is Addison's disease? What don't they make? Cortisol and aldosterone. So no aldosterone, what is going to happen? Does everyone understand that question? They don't have aldosterone. What is the role of aldosterone? Sodium. Water goes for the ride, but we retain sodium in the blood. If I don't have aldosterone, where's the sodium going to go? In the urine. So therefore, hyponatremia, because it's in the blood. We have low sodium in the blood due to low aldosterone or lack of aldosterone. Patient has a TSH secreting pituitary adenoma. What type of hyperthyroidism is this? Don't pick yellow or green because, let's see if you read these things. Read the question, read the answers. Where is the problem here? Is it the thyroid gland or the pituitary? Pituitary, so no, it's got to be secondary because primary is just the thyroid. So secondary is, now what will be a tertiary hyperthyroid or hypo? What will be tertiary be? What's the one above the pituitary? Hypothalamus. So if you had tertiary hypo or hypothyroidism, would you have, where would be the deficiency? TRH will be deficient. So you'd have low TRH, low TSH, low T3, T4. Follow it along. Bright red blood per rectum is known as what? Don't pick green. Don't read it too fast. Okay, good. Hematochezia. Not a hematoma. Okay, how is chronic gastritis associated with pernicious anemia? What is pernicious anemia? B12. So why do they have a problem? Remember, where does the intrinsic factor come from? That's where it gets absorbed. Where does it come from originally? Stomach. The lining of the stomach makes the intrinsic factor, which is why chronic gastritis affects the amount of intrinsic factor you make. Therefore, the terminal ileum has nothing to reabsorb with the B12, and you get pernicious anemia. Patient complains of abdominal pain a few hours after eating with a 5-pound weight gain. So go back when you're reading, remember peptic ulcer versus duodenal ulcer. There's when do they get hungry? When do they eat? What makes the pain worse? When does it come on? Know all those things between duodenals and peptic. Okay. What are the key things in this question that led you to believe it's duodenal? Weight gain. Why do they gain weight? They eat because it helps with the pain. Why does the pain happen hours later? It's got to get through the stomach first and then enter the duodenum where it can irritate it and cause pain. Yeah, that's pretty much all we had. So the opposite is there for the gastric. It happens right when they eat. So they don't want to eat, so they lose weight with a gastric ulcer. Which type of large intestine disease only affects the colonic mucosa? Just the mucosal layer. Okay, remember, ulcerative colitis is just the mucosal layer. Crohn's disease is what? Full thickness. All the layers are affected in Crohn's disease. Ulcerative colitis is just the mucosal layer. What's the key diagnostic indicator in a patient who has secretory diarrhea? So when it comes to the different types of diarrhea, make sure you understand the 4 different types, what causes them, what symptoms they had, especially between the osmotic and the secretory ones. Okay. What is an example of a secretory diarrhea? Cholera. Something is an infectious source. Something is turning on the pumps to keep the water flowing, so you constantly have diarrhea. So symptoms do not go away when the patient fasts because they have a secretory. Something is telling the intestinal lumen, the wall, to keep pumping water in there, causing this diarrhea to happen. You have to treat the underlying source with a secretory diarrhea. The other one was the osmotic diarrhea. What are some examples of osmotic diarrhea? Lactose intolerance, eating like the sorbitols and those weird funky sugars and stuff that our body doesn't absorb. We cause an osmotic gradient where we have more of this substance in the intestine than we do in the blood. So we start dumping water in there to dilute it out. But that causes the diarrhea to happen. So that's why with an osmotic diarrhea, when they stop eating, the diarrhea goes away because they're not eating those substances anymore that cause that osmotic gradient. So that's the difference between osmotic and secretory diarrhea. What's the name of the autoantibody in Graves' disease? These are all real ones. These aren't fake. They're all real. Okay, This is the TSH receptor autoantibody. It's going to turn on the thyroid gland. It sits in the TSH receptor. It acts like TSH. But the thing is that TSH is normally a pulsatile secretion. This is going to happen all the time. The TSH receptor autoantibody will sit in the TSH receptor all the time and keep that thyroid gland pumping. The other three are all with what? Hashimoto's, but basically they're all hypothyroidism. Anti-TSH receptor, what's that going to do? Does the same exact thing as the Graves one, but it just turns it off. So it prevents the TSH that your body is making from doing anything because these things are sitting in that receptor. Antithyroid globulin affects what with thyroid hormone? Storage. Anti-TPO, production of the hormone. What physical exam finding would you expect in a patient with Graves' disease? So remember, Graves' disease is hyper or hypo. Hyper. Then look at the symptoms. Which one goes along with hyperthyroidism? And it's hyperreflexia. Brittle hair, puffy eyelids, bradycardia are all hypothyroid symptoms. Everyone good on that one? What is the underlying pathophysiology for the weight loss seen in hyperthyroidism? Very good. Increased metabolism speeds it all up. You suspect your patient has myxedema. What would you expect her thyroid panel to show? Is myxedema, is that hypo or hyper? Hypo. Okay. Hypothyroidism, right? So high TSH, low T3, T4. The blue one, what would the question have to ask? If all of them are low, where's the problem? Hypothalamus, right? Or could be the pituitary in that one, right? Because if the pituitary has an adenoma, you're not going to make any TSH. That could do it as well. The yellow one usually doesn't happen, and neither does the green one. Well, yeah, you can have, hey, the green one, what does that mean? Or let's say there were normal TSH, normal T4, but a decreased T3. The conversion is the problem. Very good. Mom brings her 2-month-old baby in due to a hoarse cry, constipation. Physical exam shows puffed up, dull looking face. What's the diagnosis? Okay, very good. Cretinism. Which of the following is a cause of secretory diarrhea? Okay, laxatives. First, okay, lactose intolerance. Is it osmotic or secretory? Eating foods with sorbitol. Osmotic. Antacid use. Osmotic and laxatives is a secretory. It allows you to go. That's why we give it to you for like colonoscopy prep. That's why I said make sure you have the right magnesium, because one of them will make you go like crazy. One of them is good for sleep. Okay, what hormone is secreted from the D cells in the pancreas? What do the A cells secrete? B, beta, F, pancreatic polypeptide. Yeah. The pancreatic polypeptide is F. So your D cells are your somatostatin. Which of the following away issues with insulin leads to diabetes? Very good. Insulin resistance starts the diabetes, or way insulin problems lead to it. Last two. What is the mechanism for ketone body formation in type 1 diabetes? So even if you didn't know, type 1 diabetics don't have any what? Any insulin at all. So right off the bat, we know we don't have any insulin. So it's got to be lack of insulin because they don't have it at all. So lack of insulin causes breakdown of muscle and fat for energy, which is why with diabetics especially, if you give them a high protein diet, they'll keep their muscle mass, which is all the metabolically active stuff, and the ketones will just burn all the fat for them and they lose fat, they lose weight. That's how it works for them. Okay, last one. 48-year-old female, oops. Ah. I didn't mean to hit that button by accident. Hang on a second. There we go. Okay. 48-year-old female, type 2 diabetes, BMI is normal. What question in HPI can shed light on why? This is a history-taking question. So, first of all, this is a 48-year-old female, so she's 48, type 2 diabetic. So keep that in mind. We know type 2 is more strong genetic, right? So no family history of diabetes, that's not really explaining why she has no family history, but we know that's a strong component, but she doesn't have any family history. Family history of type 1 diabetes, would the fact that she may have a relative who's type 1 cause any problem with her type 2? No. Taking exogenous insulin doesn't cause diabetes. If you're watching a movie called Memento, the movie came out years ago. The guy has no short-term memory, but his wife was a diabetic, so he kept giving her insulin and didn't realize he gave her insulin already. And then she passed away and died, but it was on purpose. But anyway, yes. It was part of the movie. I watched the movie, but yeah. Because remember, obesity leads to diabetes. So she's not obese. So why is she type 2 diabetic? Because she already had gestational diabetes. So you ask her, have you ever been pregnant? Okay, when your deliveries, did you have any complications with the delivery of the baby? Oh, I had gestational diabetes. So we said before that 50% of people with gestational diabetes have a risk of developing type 2 later on in life. That was the purpose of this question. They've already set the stage in their body for diabetes while they were pregnant, so later on in life it can happen again. That's what this question was kind of getting at. Any question with this last one? Okay. Here's your scores. Very good.